Okay.
Hi, everybody. I'm Darcy. I'm the moderator for today's session. So I just wanted to let you guys know that you are in session IC08, How Complex Are CRT Users? And this is Ashley and Nicole. So before I let them get started, I want to let everyone know you can look for the CEU code. It'll be in the chat section towards the end of the lecture. And then that's also where you can put your own questions, which will be addressed later. As long as we are recording, which I think we heard we were, we can go ahead and get started. So thank you.
Okay. I guess we're all set. Okay. Okay. Checking to make sure everybody can see that, right?
Yes,
well, hi everybody. Welcome to ISS. I guess, it's too bad that we all can't be in person. But so Nicole and I are joining you from the great state of Minnesota. And we are going to talk about some of the research that we have done on just the complexities that are associated with all of our CRT users that we're really accustomed to, and what are some of the things and the trends that we're seeing with them. Oh, my slides will advance. There we go. So I'll let you introduce yourself.
My name is Nicole. I am a physical therapist. I work at a level 1 trauma center downtown Minneapolis, Minnesota. And I'm also an assistive technology professional. And I'm excited to be here. So thanks for choosing our session and listening. I think we have some really great things that you might be surprised to learn. Some things you probably also suspected that might be true about our clients. And I think, Courtney, you didn't say this yet, but if you do have questions during our presentation, go ahead and just throw them in the chat and we'll try to respond to them as we're talking if we can. Otherwise, we do have time at the end to also answer more questions.
Yep. And I am Ashley Detterbeck. I am the Regional Clinical Education Manager with Promobile, based here in the Upper Midwest. I am a physical therapist, ATP, as well as an SMS. So some of the things that we're going to talk about today is discussing the medical complications and how those how they generally affect our overall healthcare costs. We're going to identify the 5 most common medical complexities and comorbidities that occur with mobility device users, as well as describe some of the functional activities that promote the medical well-being and can prevent complications caused from just prolonged sitting. Oh my God, this thing is slow today, sorry. So first of all, let's just talk about sitting in general. And when we start talking about sitting as an able-bodied population, so all of us on the call, we know that from what the research has told us for the last couple of years, that we really are in a situation where we kind of have this epidemic in relationship to sitting. Now, if you think about the last 2-3 years now, with the pandemic, we really have become such a very sedentary society just because of the fact that we have been kind of forced to sit. So what we know from the research is that those of us that sit greater than 8 hours a day are at higher risk for cardiovascular diseases, type 2 diabetes, and certain cancers, as well as depression, and ultimately mortality. So as we sit longer throughout the day, our mortality percentage actually starts to increase. So we know that similar risks are seen in our full-time wheelchair users. And this study done in 2016 really, took a look at what our mobility users, how much they're sitting, meaning how much are they actually moving even within their seating system. And on average, they spent 10.6 hours a day just kind of sitting. Now they changed positions, slightly throughout the day, but didn't do any significant changes in their position in relationship to moving. So when we start talking about comorbidities, by definition, comorbidities is any additional entity that has existed or may occur during the clinical course for the patient. So basically, anything that comes in, following a patient's, entry into a mobility device, or, as their disease or their injury progresses, they end up, starting to get all these comorbidities. And so we really wanted to take a look and say, okay, now, we know that there's a long list of them. And I think this is just a slight list if you think about it. But on all these comorbidities, what are the most common things that we see in relationship to our end users or our mobility device users? I think a lot of us on the call immediately think like, we can list it off pretty easily: UTIs and constipation, as well as, cardiovascular issues and musculoskeletal pain. But we really wanted to take that deeper dive and try to figure out what truly out of this population of users are we really seeing, and what are some of the things that we need to, as an industry, tackle to essentially help to promote better longevity, as well as help our mobility users really be able to kind of ultimately not have to deal with some of these comorbidities. So just to give you guys a little bit of background, healthcare costs over the last couple of years have skyrocketed. I don't think anyone on the call can deny that. In 2018, about $1.9 trillion were related to hospitalizations. And in 2020, that cost was close to 1.3 trillion. Now, 2020 was a really weird year for us. So how much of that was related to COVID? It's kind of, not really noticed at this point. And then as far as our emergency visits, $8.3 billion was allotted in 2018 for just emergency costs. And so as you think about that many years ago, which kind of seems crazy that 2018 was that many years ago, all of that stuff starts to escalate and get bigger. And so as we start to look at our clients and our patients, what is that ultimately doing with all these additional comorbidities? All we're doing is just adding additional healthcare costs to an already pretty overworked system. So we wanted to go a little bit further and look at some of the healthcare costs related to UTIs, pain, as well as pressure injuries. And so there's just a little bit of some snippets of information, but we're going to take a little deeper dive. So a hospital stay in 2017 was approximately $15,000 for an individual with a UTI. And that started to, kind of as we look at it, our individuals, our clients, our patients with spinal cord injuries are at increased risk of having urinary issues. So, those that have been injured in that first 3 to 6 months post-injury, they're at an increased risk of developing kidney stones and a lot of additional urinary issues. As their level of injury increases, that risk also increases significantly. So as their level of injury, kind of moves up the spine, that risk starts to double and triple, that they start to develop all sorts of issues related to their urinary tract system. And ultimately, in most cases, this comorbidity is starting to land these individuals on hospital for lengthy stays to try to kind of clear some of these issues up. But on the opposite end of the spectrum, thanks to technology, we are aging with disabilities quite a bit. On average, our spinal cord injured individuals are living 85% longer than they would have several years ago. And the same is being seen for our clients with other comorbidities such as MS and Parkinson's. They're all living a lot longer because we have the ability now to provide some great technology to allow these individuals to live and age with their disability. But unfortunately, as they start to age with their disability, their mobility starts to decrease. They're not able to do the things that they once were able to. If they were a manual wheelchair user, they're struggling now to propel because they're just not as strong as they used to be. And maybe if they are, they're only able to go short distances. And so as that mobility starts to decrease, there's a risk of urinary issues and incontinence issues associated with just that immobility and just like kind of, being basically in a sedentary position. So with pressure injuries, we know that 22% of our patients will have a pressure injury that require rehospitalization due to their wounds. And so many of you on the call know this, you're so aware of it, you live this every day, that our clients and our patients are really, not able to heal a lot of this stuff. And so as they start to deal with these wounds and they have to be rehospitalized, they're ultimately, starting to spend more and more money in regards to just trying to get things to heal up. So, and then if you think about it, on average, 60,000 patients die yearly in just relationship to their pressure injuries. So one of the biggest issues that we have is just, that relationship to pain. So usually, pain that is treated with medication costs on average $560 to $635 billion a year. And one thing that I found really interesting is we started to look at this is that on average, 10.7 of US adults age 20 and over, and this is not related to a mobility issue, have overused one or more prescription pain medication, either opiate or non-opiates like over the counters. We really are utilizing a lot of pain medications, and 5.7 of US adults used one or more. So not only are they, getting pain medication for various things, that all that pain medication starts to compound, and they're ultimately not getting the greatest relief from it. So they add in something else and they add in something else. And so then we have another epidemic with pain medication abuse.
So as Ashley just described, we continue healthcare costs rise. And we know that our patients are the ones that are contributing to this as they continue to visit the hospitals and the urgent cares and the ED visits. So when we were looking at trying to kind of start up this research project, we also identified that a lot of times the research is very specific to one diagnosis. So they're studying a population of spinal cord injuries, population with cerebral palsy, population with muscular dystrophy. So we thought, let's look at what's going on across all mobility device users, all diagnoses, and see what we actually find. So we went back 11 years, and the initial step that I took was to run a report to see who experienced physical therapy evaluation, a wheelchair training session. Just kind of ran a big report through Epic, which is the electronic medical record that my hospital system uses, and initially pulled 857 charts. And Ashley and our heads were ready to blow up, thinking that we had to review every single one of those. And we did. So we went through each of them, and then we decided who we were going to include and who we were going to exclude. And their age range was pretty impressive. So 24 to 92 years old, but a plethora of diagnoses. And those that we excluded, some of the reasons were because they maybe started their therapy before our 11-year time period. So we couldn't include them in that data set. We also would exclude those that they might have done their evaluation within Hennepin, but then we didn't know if they actually got their device. We had some patients who died before they got their device. And then also we might have had a patient who started the process with us, but maybe they received their mobility device from a different hospital system. And so we didn't include that as well. We wanted to make sure that those that we were studying, we knew they actually got the equipment and that we felt confident that the data we were collecting was legit. So as you mentioned, we looked at a huge amount of diagnoses, and we had to group them together so statistically we can actually compare some of the results. And if you're wondering, the top two, the other without diagnosis and then the other with diagnosis. So when it was with a diagnosis, that was something such as low back pain, or maybe not your typical neurological diagnosis that we have listed there. And then the other without a diagnosis was more of the impaired mobility, the difficulty walking. So we took their primary diagnosis for needing that mobility device as this information, and then again grouped it together. the 330 devices and subjects that we looked at, we also just kind of took it and looked at which percentage was male and female, which was pretty evenly distributed. And we narrowed it down to manual chairs, power chairs with standing, and then scooters. Going back to what Ashley had mentioned with the comorbidities. So if we took our primary diagnosis as the reason that they needed that mobility device, anything that was in addition to those primary diagnoses in our chart was considered that comorbidity. We were fortunate that because Epic lists things into a problem list, we would go through that and kind of do a checkbox. Yep, they experienced this in their problem list. But then we also went through all of the physical therapy evaluation notes and looked for any of the comorbidities that were kind of in our search range. So knowing that there also could have been some that we missed or some discrepancies, we'll talk about that here. We specifically focused on 10 major comorbidities. In cardiac issues, we had things such as like asthma, COPD, hypertension, history of a heart attack. History of falls was something that was subjectively reported by the participant, and that was within the last 6 months of their physical therapy evaluation, or we had it listed as actual diagnosis as frequent falls or history of falls. Pain was something that not only was listed in their diagnosis, but also subjectively reported. And we divided that between upper extremity pain, lower extremity pain, or spinal pain. They could have any, all, or none, which we'll talk about. Incontinence was urinary incontinence. So that would be anything from like leakage to actual diagnosis of incontinence. History of wounds was a diagnosis of pressure injuries, or again, they reported they might have had a burn, and that was not looked at. We included from like lower body as well as like sacral wounds. We didn't include anything for the upper body. Digestive issues could be anything from like reflux to just GI dysfunction. Bowel was again, bowel incontinence could have been listed. We could have constipation. We could have small bowel obstruction. Swelling was either listed as upper extremity swelling, lower extremity, either or both. And then spasticity was just listed as it was present or not present. So all the comorbidities, I mean, initially we thought were overwhelming. This was probably the most overwhelming part of the entire research study. So when we had decided that the patient was going to participate in the study, we took the date of their physical therapy evaluation as our main point, and then we looked back 1 year prior and 1 year forward, and we counted how many emergency room, ED visits, urgent care visits together, urinary tract infection occurrences. So I just want to explain that if the emergency room visit led to a hospitalization, we counted that as a hospitalization. We did not separate per days. We just counted it as, yep, you were in the hospital on that day. We would kind of go through all the chart and say, yep, now you're discharged. So we had another occurrence after that. And UTIs, we initially looked for if they had that diagnosis in their problem list. And then if they did, then we would look back at those ED visits, urgent care visits, and hospitalizations and see if that was the reason that they were hospitalized or sent to the ED. So this is part where we knew that we were going to be missing some pretty important data, because if you think about it, our patients are pretty good, at least a lot of mine are good at kind of heading off if they're having the first symptoms to a UTI. So what do? They call their primary care provider, or they have a prescription refill waiting for them. And so those visits that maybe they just went in to see their doctor and they didn't lead to a hospitalization or a ED visit, those ones we missed in our data collection. And the other big thing here is that if you all don't know, but in the Minneapolis-St. Paul area, we have a huge amount of hospital systems that someone can attend. So if they didn't come specifically to the one that I work at, then they went to a different one for either hospitalization or their UTI. We weren't able to capture that data as well. So you're all sitting on the edges of your seats. You're excited. What did we find? Ready? Okay. So our study population, when you look at, again, those 330 participants in it, we definitely have an adult population, and that's me. So we do have a pediatric department. They were not included in this study. We did say when we were writing up the IRB that we were going to look at 18 and older. So our average ages for all of our subjects was actually pretty similar. Again, with the male and female split, it was pretty even. When we look at the sitting time, and this was reported, so patient comes in and the therapist asks them, do you sit how many hours a day on average? So there's that. They could have underreported or overreported, but if you look at that, like that's huge. All of them, scooters and they were a little bit over 50%, but the other mobility device users are all sitting more than 8 hours a day. So thinking back to what Ashley said, if you're an able-bodied person and you are sitting more than 8 hours a day, you're at high risk for these comorbidities. Now we have our population that is sitting because they have to, because of that disability and that diagnosis, and now they are also going to be at higher risk. So the top 5 comorbidities out of that list of 10 that we were digging through, top one is pain. And I can tell you that that doesn't actually surprise me when I have a patient that rolls into clinic and they tell me they don't have pain. That's actually what I'm more surprised about. And then I dig a little bit deeper. I'm like, really, you don't ever have pain or have headaches, neck pain, shoulder pain? And then they usually do. Cardiac issues to me was a little bit surprising, just because that's, again, if you're able-bodied and you're sitting, and we know we're at higher risk for cardiac issues, well, gosh, that's also what's happening here in our population of mobility device users. History of falls, and that was in the past 6 months, and the highest population that had falls was those scooter or POV users. And that to me made sense because those are still our patients who are transferring themselves on and off of the device pretty regularly throughout the day, versus ours who maybe are transferring into their manual chair, not as active with their transfers, or even the power chair. They're just getting in, maybe a caregiver or group home staff is putting them in. So number 3 in our comorbidities, respiratory issues and incontinence. So that is the urinary incontinence. So of the top 5, I can't say that I'm surprised, but it was also really nice to see the percentages there. So when we look at all of the percentages of these awesome people that we continue to serve, 92% had 3 comorbidities. And to me, that's pretty huge. That means that those patients that are rolling in and they tell you that they're doing great and we think that they're doing great, they're complex. This is why we use CRT, because they have a lot going on. We did have, which is unfortunate, that 1% that had all 10. And then, like you look kind of in the middle, and people definitely had more than 3, but 92% of our population is pretty staggering to think that they have seen those medical conditions, but that they're also contributing to our healthcare costs. 100% had at least one. So if anybody wants to argue, and they think about this with our payer sources and our, our insurance companies, and they say, yep, this is, oh, you just have a spinal cord injury, or you just have, why would you need all of these other things when you're justifying it? It's because they all have something else going on. We have something else going on. So to say that they don't is incorrect, but 100% have at least one, and 92% had pain. And that's huge. So as Ashley talked about, the tendency of people to overuse pain medications, and just think of, how do you feel when you are sitting all day? Or how do you feel if you're having a headache or your foot is hurting so bad that you don't want to get up and walk? Like, that really affects the rest of your life and how you're actually completing those activities during your day. So if there was a way to reduce some of these comorbidities, that I think should be explored further. When we look at the hospitalizations, the emergency room urgent care visits, and then also our UTIs, which we'll talk about, there was a large variance in our numbers of visits. And something I didn't share yet, but we are at my hospital system a level 1 trauma center. We're also the safety net hospital of the Twin Cities, and we have over 50% of our patients are government funded for their insurance. So that would be that Medicare or Medicaid. So you think about somebody going maybe once to the emergency room or being hospitalized, and that's traumatic for anybody. And then we have those that were our outliers who had 17 to 22, but most of them were kind of in that like 0 to 10 range. And think about that, cost after cost after cost is adding up. And so what do we want to show with that? That it's happening. We knew that was happening. Unfortunately, when we looked at 1 year prior and 1 year after, there wasn't a clinical difference in the amount of times that they actually attended. And one of the things that we knew that going into is that we didn't have, since it was retrospective, we did not go longitudinally. We didn't follow those subjects for more than 1 year afterwards. So do we know over time, if they got the right device, that we could continue to decrease these healthcare costs with hospitalizations? Maybe that might be another study. We'll see. When we look at the occurrences of UTIs, this is the percentage. And so on a good note, all of the different devices all went downhill. So less UTI occurrences, but the one that was most significant, and which I know was that those who had a power wheelchair with a standing function, 23% of them had a history of UTIs prior to their mobility device and evaluation, and then only 8% had one afterwards. So that is something that we think should be explored more, because that's pretty huge. And if we look a little bit closer into those who have a standing power chair, the IS is the integrated standing power wheelchairs, they also had the lowest cardiac issues. And they also had the lowest percentage of history of falls. And there is some really great research out there that talks about just, one fall leads to hospitalization, which then kind of contributes to the spiraling of more comorbidities. But something very interesting in that those who are using the standing power chairs had, of the top 5 comorbidities, they had the lowest incidence in a few of those.
So given all of this data, what can we do to help kind of shift this paradigm or shift this, this vision that we're seeing right now with all these comorbidities that are really unrelated to their disease or the diagnosis or their injury? And so, as we think back slides at the beginning, in preparation study about, what we know as able-bodied individuals that's, being seated for so long causes us all these different things. You think about how we've combat that. And many of us, probably a majority of us, have, a Fitbit or an Apple Watch or something that throughout the day is telling you stand up, it's telling you to move. And so, all of these things kind of came to fruition when we started to realize that we really did have this epidemic, that sitting was a huge issue. And so now knowing that with our clients and our patients, how are we going to kind of initiate this shift or this thought and try to help them kind of overcome some of these comorbidities as well? So that kind of the question comes up is, why are we not considering standing first? And I know the first thought that comes to a lot of you is, well, it's funding. We don't have great funding. And I completely understand that. We are located. We are, very lucky to have some great funding, state funding that supports standing. But it is one of those things that we're not going to take a dive into funding at all. That wasn't the point of this, but we definitely want to, really start to kind of shift that mind frame of, when that client or that patient comes in, rolls into your evaluation, that you're kind of taking the mind frame, and I always borrow this from Nicole because she, really speaks to it a lot, is, taking the mind frame of, you're going to prove to me why you can't stand, with all your list of stuff. And so immediately I'm thinking, when that patient comes in, okay, you know what, we're going to get you standing. Unless I find something in all of these comorbidities or in your diagnosis or your injury level that tells me, no, this isn't really an option, and we have to remain in a seated position. So we're going to talk about why we want to consider standing first and what are some of the benefits in relationship to those comorbidities that we have seen with those clients. So for many of us, we know that standing has a wide range of benefits, and the list is quite long, and it can go on and on and on. But we really just want to focus on a couple today. Knowing that the comorbidities that we saw in the populations that we studied, that that cardiorespiratory and the cardiovascular system, really that those cardiac issues kind of fell into that top 5. So we're going to talk about some cardiopulmonary. We're going to look at some of the bowel and bladder functions. Obviously, bone density. Probably whenever you say standing, whether it's a stationary stander or power standing wheelchair, bone density is kind of the first thing that everybody thinks about. And so we'll touch on it a little bit. We'll talk about some range of motion, spasticity, and of course that pressure management, because we do know that these individuals are coming in with history of wounds or have had impairment related to pressure. So we're going to start with cardiopulmonary, and just the act of standing improves your circulation, reduces edema, improves your breathing when standing. And so I am borrowing from a colleague of mine who explains it really, really well. And he said, if you think about when you work out and you become short of breath, and your first instinct is you want to sit, or you want to kneel down, or you want to put your hands on your knees, and you're thinking that that's going to help you catch your breath, when really you're supposed to stand up. And once you stand up, it helps to circulate all that good blood. It helps to kind of, move everything around, and ultimately helps you regain your breath rate, or, kind of keep you back to where you need to be. And so for our patients, it's, and clients, it's exactly the same. If they're struggling with this impaired, circulation from just sitting, we know that from sitting, they also get considerable amount of edema. All of us do if we sit for a long period of time or we travel. And, just by standing up, and that initiation of that movement can help to kind of get that circulation going and improve not only our breath, but improve our edema. So we talked about UTIs and, what we saw with those, comorbidities in our population that we studied. And, those, users of, power standing mobility had a significant reduction in their UTIs, because they were able to, stand up and ultimately reduce, and clear the bladder. And with that clearing, we are able to decrease that urinary tract infection. And so you get better bladder function by just allowing that system to be gravity dependent. That's how we were designed. And so that flow with going to standing definitely helped. And so we saw that in those individuals that we studied that utilized their power standing mobility, that they went from 23% having a UTI 1 year prior to their evaluation to only 8% having one after. And so it's a big jump between those individuals. We know, like the bladder and our urinary tract system, that our bowels are also very gravity dependent. And so by just initiating that general movement from sitting to standing, we have improved bowel function. I know that all the therapists on the call that have stood an individual up, you kind of are chuckling to yourself, because we've all experienced it, where we've stood a patient up and suddenly they're like, oh, yep, got to go to the bathroom. It's because we move in such a dynamic fashion that once we stand, it stretches that colon and it just helps to kind of get that constipation, get all that stuff kind of worked through. Like I mentioned before, we know that bone density and bone bone health is probably one of the most popular things associated with standing. It's kind of one of those things that we've heard for a long time, and we know that there's a positive impact both on children as well as adults. And so starting standing early allows for that individual to have the longevity of standing and have longer results and have better outcomes in relationship to bone health. And so because bone health is so popular with standing, it's an easy one to kind of fall back on. And a lot of our patients, or a lot of our clients that have been mobility users do often have some bone health issues. Not all of them. There's actually those mobility users that have better bone health, I'm sure, than some of us on the call. But we know that initiating standing with them early can ultimately result in better bone health and help to maintain, and in some cases, help to build that bone mineral density. Has known benefits in regards to standing. Are individuals that are sitting, while we didn't study obviously the range of motion of these individuals, it would be really interesting to see over the a period of time how much range of motion is lost. And I think as therapists, as ATPs, we know that happens, but it's kind of a different variable. But we know that standing, by introducing standing, that we can allow for better muscle length, we can allow for better hip extension, reduce some of that hip flexor tightness just from that seated position. And ultimately, in some cases, prevent that, the possibility of contractures by starting these, individuals early on in their diagnosis or early on in their injury. Once they're stable, getting them upstanding, getting them, kind of to be able to lengthen a little, allows for that improvement in their range of motion. Spasticity results have also had decreased in adults as well as children. So the people that had greater spasticity actually had greater effect from standing. So being able to bear weight through their lower extremities at times helped to reduce that increase in tone. And ultimately, with that reduction in tone, it helps them to become, in most cases, more functional. Because if they're not having to kind of combat that tone issue or that spasticity, they're really able to engage a little bit more because they're not fighting back the entire time. So, we know by increasing weight bearing through the extremities that, it allows that individual, whether, they're injured or, have the neurological diagnoses that, contribute to spasticity, to really be able to overcome that tone and become, work on being functional through the day. Of course, pressure redistribution, there's substantial offloading to the ITs when in standing. If you think about right now, we haven't been sitting all that long at the moment, but throughout the day, we're going to be standing up, we're going to be moving. If you think back to when we got to attend ISS in person, a lot of times we're up and moving, we're standing in the back of the room, and it's because we know that, hey, we got to get off our butts, it's sore, it's uncomfortable. And so the same thing goes for our clients. By just that, being able to stand up when they want throughout the day, they're able to offload those ITs. But at the same time, that doesn't negate the fact that they still need power seat functions. Obviously, they still need tilt and recline and seat elevation and elevating leg rest. We can't forgo those just to have standing, because our clients, we need that, our patients still need that. But we know that by integrating standing into the power wheelchair, that we actually can allow them to stand up more frequently and ultimately offload on their ITs. And in some cases, it's just much more socially kind of accepted. You know, if I use the kind of the example, if you think about if you're in a high school and or a junior high and you're having to sit through class or you're in a meeting and it's time for you to change your position in pressure relief, it's not as noticeable if you just really stand up in the back of the room or stand up in the back of the classroom that you're offloading versus, if you're having to do tilt, recline, and elevating leg rests, and now all of a sudden you're not able to see what's on the screen, you're staring at the ceiling. For some of our kids, we maybe lose that attention span. Or heck, some of us adults lose our attention span if we're staring at the ceiling for long enough. So that introduction of standing can not only help with those individuals with a history of wounds, but we can also help to ultimately kind of control some of that pressure redistribution. So there's a lot of medical benefits that are really important when it comes to standing. And for a long time, funding sources really only looked at medical benefits. But that doesn't negate that functional benefits are equally as important. And there's been a lot of really new recent studies regarding just that functional use in withstanding. We know that there's higher levels of independence, being able to wash your own hands, being able to reach into a cabinet. For some of our individuals, they have independence with toileting. By being able to toilet and eliminate that urine, we're also reducing that risk of UTIs. Donning and doffing our clothing, and all of build up ultimately gets some decrease, or they don't have to have that demand of care because they're able to be more with their activities. And so, as you think about today, as you kind of got prepped to come sit and listen to all the talks with ISS, think about all the stuff that you did, brushing your teeth, making your coffee, making your breakfast. For some of us, actually putting on makeup today and doing our hair, these are all things that we do. And if you think about it, we do it standing. So our clients, our patients have the same thing. A lot of them are coming back from an injury or a diagnosis to a home that isn't able to be modified. And so if we can increase some of their functional benefits by allowing them to stand and move and be engaged in their environment, ultimately we can increase their independence. And once we start to increase their independence, there's actually a higher level of involvement from the individual. Both that participation tends to kind of blossom a little bit more because they're able to engage in their environment with greater ease. So we wanted to share our study citation with you. We were joking when we put up there that we didn't realize we were the first 8 pages of that journal. But that is, kind of, this is, if you want to have more details on what we kind of take a deeper dive into our research, there is the citation. And then I'm going to let Nicole share where she's going next.
Right. So when you think back to 3+ years ago when we submitted for the research that we just shared with you and was published, I would say not my problem, but one of the things that I like to do is I think really big, and I wanted to jump right into studying those that have standing chairs and see if we can just prove right off the bat, like if you stand, you're going to reduce healthcare costs. We couldn't do that because we needed to essentially show that healthcare costs and comorbidities exist. So that was our first step. And now we are moving on to a proposal that was just submitted to my IRB and looking at those who have power standing chairs, and then looking specifically at some medical and functional outcome measures that we will be measuring over time and hoping to see some changes, positive or negative, but hoping to see some changes in those that specifically use power standing chairs. So I think we are doing okay on time. Oh my gosh, almost. Courtney, do you want to maybe go through some of the chat questions, or would you like us to open that up?
We don't have any questions at this time.
Okay.
I'll ask a question if
That
that's
would-
okay.
Hi, Britta.
Hi. Thinking about how many of our male patients actually use that standing feature to use handheld urinals or wall urinals, did you guys notice any even trends or like anecdotal differences between males and females in that great improvement with UTI prevalence? We looked at?
No, I will
Okay.
say that just because they were split. I don't know that we pulled that specifically.
Sure.
Just
It would be interesting to see if there would be any difference in actually how they're emptying bladders, or if it's surely being able to stand, right, allows you that better opening.
Absolutely. I mean, and looking at the outcome measures that will be in this next study, it's come across my mind where it's like, gosh, I should just measure like in your leg bag and then you stand up. That's not necessarily a clinical way that hasn't been standardized of measuring that. But it has, like, I've used it in some of my patients with justifying, or if they stand up and then they leave their session and they go home and have a bowel movement right away. But it's a really good point on, if you are reducing your UTIs, if there's a difference in males versus females. Yeah.
Thanks.
Welcome.
We did have a question. Someone was asking if the slides would be available.
Yes. Yeah, absolutely. Absolutely. You know what? Here, let me go to this one. Here's us. Can you, whoever was asking, I will leave this up for a little bit. And also, if you look into our attendee information, I believe my email address or Ashley's email address is listed. I'd be happy to field any questions. If you would like a copy of the slides, we can either post them through the portal, or we'd be happy to share them. And I know Ashley had said, we're not going to go into funding questions on this because that's not what it's about. We wanted to really talk about how bad sitting is for us as able-bodied, as well as all of our clients, and how complex they are. But if you do have questions and you're getting stuck and you really want to pursue standing, you can email either of us. We're happy to help.
And with that, we have another question. That do you anticipate that standing will become more common? And do you think that there will be a change with insurance?
Well, I guess we can always hope. Standing has been around for a long time. It's not like this, it's not magically new in the last couple of years. Unfortunately, it just wasn't recognized as being so super beneficial for our clients and our patients. Our fingers are crossed. There has been some large projects that Nicole and I have had the opportunity to participate in. Some large projects nationally with a bunch of different organizations to try to kind of change that view that CMS and Medicaid has on standing, as well as Seat Elevate. We know that some states have amazing funding, some not so much, and so we're really hopeful that the efforts that a lot of the individuals in the industry have put into trying to change that ultimately will allow it to be easier for everybody to access standing, as well as Seat Elevate, because we know that they're very beneficial to our clients and our patients. Unfortunately, Medicare and Medicaid don't necessarily see that in all the causes or cases, but yeah, keep your eyes and your ears open, because I think we're going to see some great things in hopefully the next year or two.
Yeah. And I mean, that was essentially kind of the base to this initial research study, and which will continue to be the rest of my research studies, is that, our insurance companies, they want the data, they want the proof that what we're proposing actually makes a difference. And so the more of us out there that can do these projects, it takes time, and it is not always easy, but it's definitely necessary. So continue to advocate, but also, if you have that idea and you think that your research would be something that would be beneficial to population, that's what matters. That's where we collect the data and we show the funding sources that this is true, and they need to be following their own rules. Anything else? Well, thank you all. This has been fun. Like we said, send us an email if you have any questions. We're both attending this week virtually. So if you have requests to meet with us, I'm happy to do that as well.
And I thank you, Ashley and Nicole, so much for that. And I just want to remind everyone that the CEU code is in the chat. I just resent it and then Darcy sent it earlier. So you might have to scroll a little with the comments that were in the chat. But thank you, ladies, very much.
Thank you.
Thank you.
Thank you, Ashley. Thank you, Nicole.
Thank you.